All right, good night, everyone. My name is Dr. Julian Yazigi. Today I'll be presenting the brain circuits regarding the thalamus and internal capsule. So for today's objectives, we have to understand the anatomy and spatial relationships of the thalamus and the internal capsules, as well as to identify all major thalamic nuclei and their functions and connections. We have to be able to correlate the vascular territories with the clinical syndrome, as well as to describe the fiber organization of the internal capsule, and ultimately explain the clinical and surgical significance the thalamus internal capsule interface. So I'll begin with the thalamus, then proceed to the internal capsule, and finish by explaining why the interface between them is a single clinical unit with relevance to stroke neurology, tumor surgery, and functional neurosurgery. Okay. So let's start off by talking about the anatomy a bit. The thalamus, as pictured here, is a paired ovoid structure derived from the diencephalon, and it forms the lateral walls of the third ventricle. Medially, it's bordered by the ependema of the third ventricle, and laterally, it's bordered by the internal capsule. Superiorly, it relates to the body of the lateral ventricle, and inferiorly, it transitions into the hypothalamus and subthalamus. Posteriorly, it expands into the pulvinar, and at the posterior inferolateral corner, it gives rise to the lateral geniculate nucleus and the medial geniculate nucleus, which are essential for the visual and auditory radiations. Okay. In approximately 2/3 of individuals, there's an interthalamic adhesion, also called the massa intermedia, which connects the two thalami. It doesn't really represent a true functional commissure and doesn't contain any meaningful commissural fibers. The internal architecture of the thalamus is organized around two laminae. The internal medullary lamina is a Y-shaped sheet of myelinated fibers that divides the thalamus into an anterior nuclear group, a medial nuclear group, and a lateral nuclear group, and we'll go into details of those shortly. The external medullary lamina lies on the lateral surface and separates the thalamus from the thalamic reticular nucleus, which forms a shell alongside the outside of the thalamus. A key functional principle is that the thalamus is not just a relay station. I know it's displayed there in the image. In truth, each relay nucleus receives a driver input, which is the primary information stream, and it also receives a larger modulatory input from corticothalamic projections, especially from cortical layer 6, as well as the brainstem and neuromodulatory systems. The architecture allows for things like gating, amplification, suppression, and synchronization of information before it reaches the cerebral cortex, and it underlies attention, as well as sleep rhythms and generalized seizure physiology. Okay, so let's dive right into the nuclei. So let's start by talking about the anterior group. Okay, I'm going to go through this systematically. The anterior nuclear group contains the anterior dorsal nucleus, the anterior ventral nucleus, and the anterior medial nucleus. These nuclei are core components of the Papez circuit, and their main afferent input arrives through the mammillothalamic tract. Okay, this carries signals from the mammillary bodies, and in turn, it receives hippocampal contributions via the fornix. Their main efferent projection is to the cingulate cortex, and functionally, these nuclei are involved in episodic memory consolidation and emotional salience. All right, lesions can produce prominent memory impairment, confabulation, and thalamic dementia patterns. That's very important to recall. Okay, so from a vascular standpoint, the anterior nuclear group is often supplied by the polar artery, also called the tuberothalamic artery, which commonly arises from the posterior communicating artery, or PCA. This vessel is anatomically variable. It can be absent, and in such cases, the territory can be supplied by the paramedian perforators. From a functional neurosurgery standpoint, the anterior thalamus has been used as a neuromodulation target for epilepsy because of its limbic connectivity. All right. Progressing on to the medial group. The medial group is dominated by the mediodorsal nucleus, also called the dorsomedial nucleus, which has magnocellular and parvocellular subdivisions. Its afferent inputs include the amygdala, olfactory and limbic systems, basal ganglia contributions, as well as prefrontal cortical feedback and brainstem monoaminergic systems. Its efferent projections are primarily to the prefrontal cortex, especially the orbitofrontal and medial prefrontal regions, as well as to the anterior cingulate cortex. Functionally speaking, it's critical for executive function, motivation, affect regulation, and working memory. Lesions to these, especially to the medial dorsal nucleus, can cause apathy, disinhibition, impaired judgment, and dysexecutive syndrome. And in the dominant hemisphere, it can even contribute to thalamic aphasia patterns, right? Clinically, deep midline thalamic pathology involving this region can present with behavioral change that may be misinterpreted as primary psychiatric disease early on. As far as the vascular supply, it commonly involves paramedian perforators from the first segment of the posterior cerebral artery, but it can also overlap with the polar artery territory, depending on the individual pattern, right? Moving on to the lateral group, the dorsal tier. The lateral group is the largest and is divided into a dorsal tier and a ventral tier. Starting with the dorsal tier, this includes the lateral dorsal nucleus, the lateral posterior nucleus, and the pulvinar. The lateral dorsal nucleus receives limbic and hippocampal associated inputs and projects to the cingulate cortex, participates in limbic association and spatial learning. Lesions can contribute to memory and limbic integration deficits. The lateral posterior nucleus receives its inputs from the superior colliculus and from the parietal association cortex and projects to the parietal association cortex as well. It's involved in multimodal sensory integration and attention, and lesions may produce neglect-like phenomena and attentional deficits. The pulvinar is a large posterior thalamic nucleus. It receives inputs from the superior colliculus, from visual association cortices, and it projects broadly to parietal, occipital, and temporal association cortices as well. Functionally, it coordinates visual attention, salient selection, multimodal integration, and orienting responses. Lesions often produce hemispatial neglect, particularly in non-dominant hemispheric lesions, and may also cause visual attention deficits and impaired saccadic selection. Its vascular supply is largely from the posterior choroidal arteries, arising from the posterior cerebral artery. From a neurosurgical standpoint, it's here that the pulvinar and lateral posterior involvement can mimic cortical neglect syndromes even without a cortical injury, which is important for image interpretation and lesion localization. As far as the ventral tier of the lateral group, it contains the key motor and sensory relay nuclei, the ventral anterior nucleus, the ventral lateral nucleus, and the ventral posterior nucleus. The ventral anterior nucleus receives inhibitory output from the internal segment of the globus pallidus and from the substantia nigra pars reticulata. And it projects to premotor cortex and supplementary motor cortex. Okay? Its function in motor planning is, very vital, as well as in the initiation through basal ganglia thalamocortical loops. Lesions can produce impaired initiation, akinesia patterns, and dystonia-related manifestations. The ventrolateral nucleus receives cerebellar outflow, especially from the dentate nucleus, through pathways involving the superior cerebellar peduncle, and it also receives basal ganglion contributions in some subdivisions. It projects to the primary motor cortex and premotor cortex, and its function is tuning of motor execution and coordination. It's intimately related to tremor circuits, so lesions can cause intention tremors, ataxia, and dysmetria-like motor control deficits, right? Within the lateral ventricle region is the ventral intermediate nucleus, which is a clinically crucial functional subdivision used as a target for deep brain stimulation for essential tremor and tremor predominant Parkinson disease. The ventral posterolateral nucleus receives ascending input from the medial lemniscus and spinothalamic tract carrying contralateral body sensory information. It projects to the primary somatosensory cortex in the postcentral gyrus, and lesions produce contralateral loss of pain, temperature, vibration, and proprioception in the body, and can precipitate central pain syndromes. The ventral posterior medial nucleus receives trigeminal thalamic input conveying facial sensation and also receives gustatory input from the nucleus of the solitary tract. It projects to the facial region of the primary somatosensory cortex and as well to the gustatory cortex in the insula and frontal operculum. Lesions produce facial sensory loss, but may also cause taste disturbances. An additional nucleus relevant in pain physiology is the ventral posterior inferior nucleus, which receives spinothalamic and brainstem nociceptive inputs and projects to the insula and secondary somatosensory cortex. This nucleus contributes to pain perception, integration, and is relevant to neurosurgical pain modulation strategies. A key clinical linkage is that pure sensory stroke syndromes commonly arise from infarction in the ventral posterior nuclei, particularly in territories supplied by the thalamo-geniculate arteries. All right. Moving onwards to the intralaminar nuclei and the midline nuclei, within the internal medullary lamina are the intralaminar nuclei. These include the centromedian nucleus, the parafascicular nucleus, the central lateral nucleus, and the central medial nucleus. These nuclei receive inputs from the reticular formation pain pathways, which include components of the spinothalamic system, basal ganglia networks, including striatal interactions, and brainstem arousal systems. They project diffusely to cortex and also strongly to the striatum. Functionally speaking, they mediate arousal, attention, pain, salience, seizure networks, and basal ganglia modulation. Lesions can impair arousal and attention, and bilateral involvement can produce coma-like states. From a functional neurosurgery perspective, centromedian and parafascicular regions have been used as targets in refractory epilepsy and explored as well in pain and movement disorders. Adjacent to the third ventricle lie the midline nuclei, including the paraventral nucleus, parotenial nucleus, Reunion's nucleus, and rhomboid nucleus. These nuclei connect limbic structures, hippocampal systems, and medial prefrontal cortex, supporting memory integration, emotional regulation, and arousal. Lesions may cause amnesia, altered arousal, and limbic dysregulation, and they help explain why relatively small midline thalamic lesions can have very disproportionate behavioral and memory effects. Moving on to the geniculate nuclei, at the posterior thalamus are the geniculate bodies. The lateral geniculate nucleus receives retinal ganglion cell input through the optic tract, as well as the input from the superior colliculus and strong feedback from visual cortex. It projects via the optic radiation to primary visual cortex along the calcarine fissure, and lesions produce contralateral homonymous visual field deficits depending on the level that's involved. Its vascular supply is largely from the cerebral artery, the posterior cerebral artery, with contributions from the anterior choroidal artery in some regions. The medial geniculate nucleus receives auditory input from the inferior colliculus via the brachium of the inferior colliculus and projects via the auditory radiation to primary auditory cortex in Heschel's gyri. Lesions typically produce subtle auditory processing deficits rather than complete deafness because of the auditory representation. Thalamic reticular nucleus, which is lateral to the external medullary lamina, is a thin shell of gamma aminobutyric acid producing neurons. It receives contralateral input from thalamocortical and corticothalamic fibers and sends inhibitory projections back to other thalamic nuclei. Functionally, it gates thalamocortical traffic and regulates oscillations underlying sleep spindles and generalized epilepsy. Although it's not a standard direct surgical target, it is central to thalamocortical rhythm disorders. Okay, that's just to kind of go through each nucleus and its relevance and function to us from a neurosurgical and functional standpoint. We can't talk anatomy and function without talking about vascular territories. I did go over the vasculature regarding each nucleus, but I'll go over it a little bit more here. Right? So the tuberothalamic or polar territory commonly arises from the posterior communicating artery and supplies the anterior nucleus and parts of the mediodorsal nucleus. Infarction would cause memory and executive and limbic deficits. The paramedian territory is supplied by the paramedian thalamoperforators from the first segment of the posterior cerebral artery and supplies the medial thalamus, as well as the intralaminar nuclei, and it may even involve the rostral midbrain. Infarction here causes decreased consciousness, reticular gaze palsy, and memory impairment. Moving forward to the inferolateral territory, this is supplied by the thalamo-geniculate arteries from the second segment of the posterior cerebral artery and supplies ventral posterior nuclei and ventral lateral nuclei. Infarction commonly produces pure sensory stroke in this situation. It has potential motor or tremor involvement depending on the extent, but primarily it's pure sensory stroke. The posterior territory, on the other hand, is supplied by the posterior choroidal arteries and supplies the pulvinar and geniculate regions, producing visual attention deficits or visual field deficits. A critical variant is the artery of Percheron, where a single trunk supplies bilateral paramedian thalami. An occlusion usually leads to sudden coma, vertical gaze palsy, and profound memory impairment. Classic thalamic pain syndrome is the Dejerine-Roussy syndrome, which usually involves the ventral posterolateral nucleus injury, and it's characterized by contralateral sensory loss followed by severe refractory central pain. All right, so we've covered the thalamus and its nuclei as well as its vascular territory for the most part. Let's briefly go through just about the same for the internal capsule. And also the internal capsule is a compact white matter structure that carries nearly all ascending and descending projections between cerebral cortex and subcortical structures. Conceptually speaking, it's a bottleneck because the fibers converge into to form the corona radiata, traverse it, and then diverge into brainstem pathways and thalamic radiations. Clinically, the concentration explains why very small lesions can produce very dense deficits. The internal capsule can be divided into the anterior limb, the genu, the posterior limb, retrolenticular part, and sublenticular part. All right, and let's talk a little bit about that. So with regards to the anterior limb lies between the head of the caudate nucleus medially and the lentiform nucleus laterally. It contains the anterior thalamic radiation, which connects anterior and mediodorsal thalamic nuclei with prefrontal cortex. It also contains frontopontine fibers from the prefrontal cortex to the pontine nuclei. Lesions of the anterior limb classically produce executive dysfunction, abulia, and impaired planning rather than pure motor deficits, unless adjacent structures are also involved. Its blood supply includes the recurrent artery of Hübner from the anterior cerebral artery and contributions from the lenticular striate arteries. In between, we have the structure called the genu, and this contains corticobulbar fibers descending from the motor cortex to cranial nerve motor nuclei. It includes pathways relevant to the trigeminal motor system, facial motor system, glossopharyngeal, and vagal motor systems, as well as the hypoglossal motor system. It also contains, to some extent, frontothalamic connections. Lesions often produce dysarthria and contralateral lower facial weakness and may even contribute to dysphagia depending on the extent and bilateral representation. Its primary blood supply is the lenticular striate arteries arising from the middle cerebral artery. And we move even further down to the posterior limb, which lies between the thalamus medially and the lentiform nucleus laterally. It contains descending corticospinal fibers, which are somatotopically organized with face anterior then arm, then trunk, and leg more posteriorly, with some individual variability, of course, but strong clinical reliability as such. It also contains ascending thalamocortical sensory fibers traveling from the ventral posterior thalamic nuclei to primary somatosensory cortex, and their close proximity to corticospinal fibers explains why lacunar strokes can produce combined motor as well as sensory syndromes. The posterior limb transitions posteriorly into parts carrying optic and auditory pathway fibers through its retrolenticular and sublenticular extension. The vascular supply of the posterior limb is very crucial. The posterior portion of the posterior limb is supplied predominantly by the anterior choroidal artery, and more anterior components can be supplied by the lenticulo-striate branches. Occlusion of the anterior choroidal artery produces the classic triad of contralateral hemiplegia from corticospinal involvement, contralateral hemisensory loss from thalamocortical sensory fiber involvement, and homonymous hemianopia from involvement of the optic pathway fibers. Though the complete triad is variably present depending on the exact infarct distribution, as well as the collateral supply. The retrolenticular part contains optic radiation fibers, particularly superior and parietal components, as well as posterior thalamic radiations to the parietal and occipital association cortex. Lesions often produce contralateral homonymous hemianopia, which is often dense. And as so far as the sublenticular part, it contains the temporal optic radiation, including the Mayer loop, and contains auditory radiation fibers to primary auditory cortex, as well as temporopontine fibers. Lesions here may cause contralateral superior quadrantanopia from Mayer loop involvement and may cause subtle auditory processing deficits as well. So let's talk about how these two structures serve as a single clinical and operative unit. All right, the thalamocortical fibers leave the thalamus and immediately funnel into the posterior limb of the internal capsule before fanning out to the cortex. Right, you can see as demonstrated in the illustration there. What this does is it creates a bottleneck effect in which small lesions can disconnect large portions of cortex. And this explains why even a small inferior lateral thalamic infarct can produce a very dense sensory deficit, why a small capsular lacune infarct can produce striking pure motor hemiplegia, and why thalamic hemorrhage can produce major weakness if it compresses the posterior limb. In the operating room, this interface means that we have something of a zero margin region. Deep lesions adjacent to the thalamus risk internal capsule injury through edema, retraction, thermal spread, or even vascular compromise. For that reason, we often rely on diffusion tensor tractography to visualize corticospinal and thalamocortical fibers, as well as having patients on continuous intraoperative neurophysiological monitoring and subcortical stimulation to preserve function during sections near the posterior limb. From a functional neurosurgery perspective, the ventral intermediate nucleus within the ventral lateral region is a principal target for deep brain stimulation in things like essential tremor and tremor predominant Parkinson's disease, as we had mentioned earlier in the presentation. The centromedian and parafascicular regions of the intralaminar nuclei are relevant in refractory epilepsy and pain neuromodulation. And the anterior thalamus is relevant in epilepsy neuromodulation because of its limbic circuit connectivity. All right, so that concludes my presentation for the date. And let's talk about some key takeaways, right? So let's just always remember the thalamus is an active regulator, not a passive relay. Each thalamic nucleus has specific cortical connections, as well as predictable deficits, which help to localize lesions. Small thalamic infarcts produce very distinct syndromes due to end artery supply. The internal capsule is a final common pathway where small lesions cause large deficits. Thalamus and internal capsule function as a single critical clinical and integrational unit rather than two separate and independent structures. And these are my references. Thank you, everyone.